Hello, my name is Shannon Brooks. I am a Regis College student, and today I'm going to be discussing contraction stress test. What is a contraction stress test? A contraction stress test is when there is a risk for a fetal hypoxic injury or fetal demise, a contraction stress test will be performed. It is performed to determine how well the fetus will deal with contractions, labor, or an induction. We use it for patients that have had a recent demise, high-risk pregnancy, diabetes, that are post-dates, have had abnormal BPPs, or non-stress test. What to expect? What to expect is after 32 weeks gestation and over, women will have these tests performed. 2 straps will go across their abdomen. Each strap will have a small round device on it. One of the small round devices is a toco. A toco is a device that is placed on the top of the uterus. So when your uterus contracts and tightens, the toco pushes against your uterus pushes against this toco, which picks up the contractions on a fetal heart rate monitor. The second is an ultrasound. The ultrasound monitor will pick up the fetal heart rate. It will have to be adjusted according to if the baby's moving around or mom repositions herself. The fetal heart rate is important to pick up with the contraction because we want to watch for what the fetal heart rate is baseline, what it does prior to a contraction, during, and after a contraction. So we can see if the baby has any fetal distress with being squeezed and cannot tolerate it. You will have Pitocin going through the IV. That will be started at 2 mLs an hour or per protocol. It is increased every 30 minutes. So it may take a couple hours until your contraction pattern picks up to get to our goal of 3 contractions within 10 minutes. Based on if you are nulliparous or multiparous, the time will differ. Nipple stimulation is encouraged during contractions, help bring on oxytocin, your body's natural oxytocin that stimulates and helps bring on labor. The history of CST is in the 1980s. Studies proved that CST and non-stress test help decrease risks associated with fetal demise. The studies proved that it helped determine if a fetus would end up having to not be able to tolerate labor or an induction. Recent studies have showed that it helps allow interventions before fetal acidemia and acidosis kicks in. Tanaka 2019 study that I discuss is with a fetus that was diagnosed with fetal growth restriction, and the outcomes proved that the CST and NST helped determine the infants would be able to tolerate labor. Studies help this risk prior to delivery. After delivery, we perform something called a cord pH. A cord pH is when we take a segment of the cord between the placenta and the infant, and it is clamped off. We draw off the arterial and the vein vessel that we can check through lab work to determine if there was a decrease in gas exchange, hypoxia, metabolic, acidosis, or respiratory. Contraindications: anyone who has been diagnosed through ultrasound with a placenta previa, vasa previa, if they have had a previous classical C-section, that is not the same as a lower transverse section that most women have. Classical is due to normally an emergency situation. If they have had preterm labor or have preterm labor with this pregnancy, or PPROM, which is also known as premature rupture of membranes. Advantages and disadvantages is They're not often performed as frequently as NSTs due to contraindications. Many women have a lot of contraindications, so we're just able to do the non-stress test instead. Non-stress tests are less timely as well. Non-stress tests are 20 minutes, and contraction stress tests can take a significant amount of time. Also, advantages is it helps identify the fetal distress, interruptions of fetal oxygen. You can avoid a stat C-section by determining if there will be fetal intolerance with labor. The disadvantages is it can jumpstart labor. So you want to make sure that if you do perform it, that they are over 37 weeks. May take a long period of time to bring on contractions, can cause discomfort because the Pitocin is a synthetic way of sending your body a message to have contractions to bring on labor. Discomfort cause fetal distress, or they're also less convenient, as I just discussed, for the length of time than non-stress tests. Interpretations, you want to review the fetal heart rate tracing during the time. If it is positive, we do not want to prolong it. We want to stop the Pitocin and let the baby recover. We do not want to continue to stress out the fetal heart rate. Late decelerations are a positive sign. We want the late decels to be more than 50% of contractions. So usually they have to be repetitious in late decels. If you just have one late decel and that's it between two different contractions, then you always can reposition the patient. You can give IV fluids, and you can also give oxygen by mask. But normally, sometimes a late decel can happen if the mom is leaning on a certain position, and usually repositioning helps lift that baby off the cord if it's due to that. Late decels are defined as a symmetric fall in heart rate beginning at the nadir of the contraction and following, returning to baseline after the contraction is at rest. Late decels do show that there is fetal distress and interruption in oxygenation. Negative is there is no late decelerations, there is moderate variability and contraction frequency. The baby tolerates before, during, and after a contraction and is having 15 by 15 accels before and during a contraction. Unsatisfactory is there are not enough contractions to produce a result, so they're not 3 contractions within that 10 minutes to decide if the baby would be able to tolerate or not. And then equivocal results of the test are unclear. This is a picture of a CST. This is a short 5-minute picture of a fetal heart rate tracing. This woman is 39 weeks gestation, a multi-paris patient, approximately 5 minutes of the strip. The contractions right here, we only have 2 contractions and they're 3 minutes apart. But this is to show you what a late deceleration looks like. And the late deceleration happens at the peak of the contraction. The fetal heart rate starts to go down, and right here, and the fetal heart rate falls following the contraction and then comes back to baseline after the contraction and when the contraction has been gone. This would be a positive CST if these lates are repetitive and interventions have taken place and it has stayed like this. There is also minimal variability as well in this picture. So both those things show me that there is interruption of oxygen and the baby is not going to tolerate labor or an induction. For follow-up after a positive result, we want to further evaluation. We want to make sure we can do a PPP if we needed to, if there was not one prior. we can also, based on the mother's situation and how many weeks she can prepare for delivery. Delivery, if late decelerations, no trial of labor. We will just go straight to a C-section, and that category of the tracing that I showed you prior would be a category 3 tracing. Negative follow-up in 1 week, you can continue with NSTs and BPPs. Thank you, and I will take all questions now. Have a great day.